So let's talk a little bit about the basic clinical pharmacology of the medication we use that affect the autonomic nervous system. And starting with the cholinergic drugs, start with muscarinic antagonists. These are like atropine-like drugs. So atropine, scopolamine, glycopyrrolate. They inhibit salivary, bronchial, pancreatic, and generally GI secretions. They antagonize the muscarinic side effects of the anticholinesterases like neostigmine when you reverse the muscle relaxants. Atropine and scopolamines are tertiary amines. You will be asked this question multiple times in multiple exams. So the tertiary amines can penetrate the blood-brain barrier, and placenta, glycopyrrolate, is a quaternary amine, has a positive charge. So, like the reversible anticholinesterase drugs, they don't easily penetrate the blood-brain barrier. What is central anticholinergic syndrome? This is also known as post-op delirium, atropine toxicity, and the central anticholinergic syndrome. So, atropinic alkaloids can cross the blood-brain barrier, and they can very rapidly produce dry mouth, blurred vision with photophobia or mydriasis, hot and dry skin that is flushed, as well as fever. Mental symptoms range from sedation, stupor, and coma to anxiety, restlessness, disorientation, hallucination, and delirium. They can also be convulsion if lethal poisoning has occurred. Intoxication, though, is usually short-lived and is followed by amnesia. These reactions can be controlled by IV physostigmine, but when you diagnose it, just because somebody has central disorientation doesn't mean that they have central anticholinergic syndrome. There should be peripheral signs of antimuscarinic activity in addition to central anticholinergic syndrome. So what are the compounds that are associated with central anticholinergic syndrome? So here's one of the lists. There are multiple lists with lots of weird things, but here I've noted the things that we commonly use. So, of course, the atropine and scopolamine, cocaine, not that we use it, but sometimes we give it to patients still. Antihistamines, anti-Parkinson drugs, the antipsychotics, and the TCAs, and also meperidine and methadone. Don't forget about those. So briefly on sympathomimetic drugs, one thing to remember is the catecholamine receptor effector coupling. The net physiologic effect of the sympathomimetic action is usually defined as kind of an algebraic sum of its relative actions on different receptors, alpha, beta, and dopamine. Most of these adrenergic drugs activate or block these receptors at the same time to a varying degree. But each catecholamine has a distinctive effect on myocardium and peripheral vasculature, both qualitatively and quantitatively. But remember, this relative potency is dose related. That's why, at least theoretically, different dosing of norepinephrine or epinephrine can result in different effects.